Hello, my name is Megan. This is a video presentation for NSPN 7155, Breastfeeding Theory Experience. This presentation is on the breastfeeding challenge of flat or sore nipples in an infant with jaundice. I will be using the situated clinical decision-making framework in order to guide this presentation. This framework includes knowledge, cues, judgment, decision, and evaluation. It provides a structured approach to guide clinical decision-making in practice. The first part of the situated clinical decision-making framework is knowledge. Let's talk about jaundice. Jaundice is caused by the buildup of bilirubin in the newborn. Bilirubin is formed with the breakdown of red blood cells and must be conjugated in the liver in order to be excreted. Newborns are at greater risk for jaundice due to an increased red blood cells as well as a shortened lifespan of red blood cells. Additionally, an immature liver of the newborn decreases the ability to conjugate bilirubin. Once conjugated, bilirubin can be excreted into the duodenum as bile. It is then removed from the body in the form of urine and feces. It is essential to remove bilirubin, as free bilirubin can cross the blood-brain barrier and cause neurotoxicity. The ability of the newborn to excrete bilirubin is dependent on the stooling patterns. Therefore, feeding is important to stimulate peristalsis and increase the passage of meconium. Colostrum further aids this as a natural laxative. A lack of breastfeeding contributes to an increased serum bilirubin. The newborn is not feeding well. They have a decreased caloric and fluid intake, which leads to decreased stools. Any bilirubin not excreted can be reabsorbed by the intestine, thus further increasing serum bilirubin. Jaundice is classified as either physiological or pathological jaundice. Physiological jaundice usually presents within the first 24 hours to 7 days in a full-term newborn. In a preterm infant, it may be evident in the first 48 hours to 10 days. In both cases, it usually resolves without treatment. Pathological jaundice is the result of an underlying problem, such as a hemolytic disease in a newborn or a maternal newborn blood group incompatibility. It usually appears in the first 24 hours of birth and requires treatment of the underlying problem to resolve. Hyperbilirubinemia and the resulting jaundice is diagnosed on the gestational age, the hours or days of life, and the baby's general condition. The hour-specific nonogram provides guidance as to the severity of hyperbilirubinemia and if treatment is required. Now let's discuss breastfeeding challenge of sore or flat nipples. Many women find that they have sore nipples from breastfeeding. While some of these women report tenderness at the beginning of a feed, severe soreness or painful, cracked, scabbed, and bleeding nipples are not normal. Most commonly, sore nipples are a result of poor positioning, incorrect latch, or an infection. The key to preventing sore nipples is to ensure correct breastfeeding technique. It is essential to ensure rapid healing of sore nipples in order to maintain breastfeeding and prevent mastitis. In order to obtain a correct latch, the infant should be breast to chin with the mouth wide open. The nipple should be aimed at the roof of the mouth in order to elongate the nipple to where the hard and soft palate meet. If an incorrect latch is suspected, suction should be broken with the finger into the infant's buccal pouch in order to reposition and prevent nipple damage. Sore nipples can also be the result of a yeast infection. In this case, the mother often reports pain disproportional to the presentation of the nipple. If an infection is suspected, both mother and infant should be treated. Some women have flat or inverted nipples, which lead to difficulty breastfeeding as the infant may have a difficult time latching to the breast. In order for the infant to successfully breastfeed, they must be able to grasp the nipple and stretch it forward and upward to the roof of the mouth. Infants have a very difficult time nursing from engorged breasts with flat or inverted nipples, as the engorgement pushes the flat nipples out, making them even harder to grip. With flat or inverted nipples, it is essential to breastfeed every 2 to 3 hours to prevent engorgement. When women have sore or flat nipples, it may be difficult to ensure that the newborn has adequate caloric intake. However, jaundice babies need ample intake to ensure the excretion of bilirubin and prevent further complications from hyperbilirubinemia. We will continue to use the framework to evaluate the infant condition and breastfeeding challenge. Cues. Cues are observations or assessment data which must be considered with the breastfeeding challenge and the newborn. Jaundice is characterized by a yellow discoloration of the skin, mucous membranes, and sclera. In order to assess for jaundice, pressure is applied with a finger over a bony area, such as forehead or chest, for several seconds. When the finger is removed, the blanched area will appear yellow until this skin tone returns. The degree of jaundice can be evaluated either using non-invasive monitoring or blood work to determine the bilirubin levels. Transcutaneous bilirubinography can be used by placing on the newborn's skin in order to provide repeat estimates of serum bilirubin. Heel stick can also be used to obtain a precise serum level. The serum bilirubin value is based on the hour-specific nonogram in order to determine what is a level of concern. The output of the newborn should also be monitored to ensure that there is adequate intake. On the first day of life, the newborn should have 1 void and 1 stool. On the second, they should have 2 voids and 2 stools. This should continue until day 5, when the infant should be having frequent voids and 5 to 10 stools per day. The infant should also start gaining weight by day 5 with a return of birth weight within the first 2 weeks. Some women experience cracked nipples with extreme pain. Nipples should be assessed for redness, bruising, blistering, and scabbing. Breast should also be assessed immediately after breastfeeding for misshapen or distorted nipples. As mentioned, this is often a result of an incorrect latch, poor positioning, or an infection. Once adjustments in positioning and latch have been made, if the mother complains of little to no improvement, other causes for pain should be assessed. Sucking problems, a retracted or improperly positioned tongue, strong clenching reflex, infection, or improper breast pump use are possible causes of nipple soreness. Judgment. Judgment is used to determine the priorities of this breastfeeding challenge and infant condition. When a mother is experiencing nipple soreness or difficulties breastfeeding due to flat or inverted nipples, it is essential to ensure that the newborn has adequate intake of breast milk to ensure peristalsis and the excretion of bilirubin. It is also critical to resolve the underlying problem in order to ensure continued breastfeeding. In newborns with jaundice, bilirubin levels should be monitored carefully to ensure appropriate clearance and prevention of neurotoxicity. If the liver is unable to clear the excess bilirubin, phototherapy may be required. In some cases, neonatal hematologists are consulted for exchange transfusions in order to resolve pathologic jaundice. It is also important to remember that correct latch and positioning must be learned by both the mother and infant in order to promote a healthy breastfeeding relationship. Sore nipples and difficulty breastfeeding are major reasons women stop breastfeeding altogether. In difficulties with latch or positioning despite continued attempts at correction, a lactation consultant may be required. Public health may also be consulted to monitor both mother and babe in the community. Now I will talk about decisions where treatment and nursing support will be considered. Various tools and techniques may be utilized in order to provide an effective latch and allow nipples to heal appropriately. The Hoffman technique can be used to help move a flat nipple outward. The breast sandwich method can help get more breast tissue into the infant's mouth. Breast pumps can be used not only to collect breast milk, but also used immediately prior to breastfeeding in order to pull the nipple out. Breast shields can also be used immediately prior to breastfeeding to assist with pulling out the nipple for easier breastfeeding. When allowing the nipples to heal, women are encouraged to feed from the least sore nipple. Hand expression of milk prior to feeding may also stimulate letdown and reduce the suckling from the newborn. After feeding, it is suggested that the newborn's saliva is wiped from the nipple and a few drops of express milk are rubbed on. Sore nipples should be open to air in order to promote healing as much as possible. If the nipples are so sore and damaged that the mother can't tolerate breastfeeding, hand expression of milk or a breast pump should be used for short durations to allow the nipples to heal. The resulting milk can then be cup-fed or dropper-fed to the babe to ensure adequate intake. Providing the mother with the effective and appropriate tools and knowledge will allow her to make effective decisions about breastfeeding and the care of her infant. The jaundice of the infant should be continually monitored in order to ensure resolution. If there is suspicion of worsening jaundice, the infant should be referred to a physician. Lastly, evaluation. This is a time in the situated clinical decision-making framework to self-reflect on the management of the breastfeeding challenge. It is an opportunity to ensure both mother and infant have received the care they required. With this particular situation of sore nipples and jaundice, the resolution of jaundice and healing of mother's nipples would demonstrate appropriate management. I hope you enjoyed this presentation. Thank you.